Hello, everyone. Thank you very much for coming to our presentation. Thank you very much to the American Acupuncture Council for having us. My name is Matt Callison. I'm here with my dear friend and colleague, Brian Lau.
Hi, thanks for having us again.
Brian and I were talking the other day, and we were discussing our topic for this particular presentation. We've got the Module 1 presentation coming up for the SMAC program and has a lot to do with the vertebral fixations and sacral fixations and how they can contribute to patients' pain. And this particular one with the occiput and the atlas is a very, very important one for acupuncturists to know. So we wanted to be able to shed some light on this particular fixation and how it can contribute to a number of different injuries. So, without further ado, we've got quite a bit to get through. So, why don't we go to the next slide there? All right. So, in the certification program, Sports Medicine Acupuncture Certification Program, in Module 1, we look at the role that vertebral and sacral fixations play in the patient's complaints, including musculoskeletal conditions, but also Zong Fu when there's vertebral fixations in the thoracic region. Now, in this particular presentation, as I mentioned before, we're going to introduce the Occiput-C1 fixation that's going to be taking place at the atlanto-occipital joint. Now, this fixation can cause many patient complaints such as cervicogenic headaches, muddled or cloudy thinking, neck pain, and for that matter, also it can contribute to jaw pain, low back pain, and a very interesting psoas strain because of the association that this fixation has with bilateral psoases that we're going to touch upon here in just a little bit. So why don't we get started about what is a vertebral fixation with the next slide. So a fixation complex is going to be the compression and torquing of one vertebra on top of the other. Now, the locking of the vertebrae together creates a hypomobile. It just fixates. Those two vertebrae or even three vertebrae that lock together have a lack of mobility within that segment of the spine, which is going to be further restricted with myofascial and also ligamentous adaptations holding that fixation in place. Now, the facet joints can be locked into a compression, into rotation. It can be tilted to left and right sides. In the sports medicine acupuncture program, we also discuss how the thoracic vertebrae can be stuck in flexion and also into extension. So if you can take a look here, it's as if the vertebrae, when it has a compression and torquing, it just locks one on top of the other. And it may not actually look like it's out of alignment. Many times the vertebrae actually feel like they're in place, but they end up not moving very well. They get stuck with one another. That causes aberrant motion within the region. And the more chronic that fixation is going to be in place, it starts to then affect the spinal nerves itself. So acupuncture and manual techniques work extremely well to be able to open up these fixations and get more energy to the Zong Fu and also the innervated tissue of the musculoskeletal system. So what's on the, let's go right into that Occiput-C1 here. All right, so we're going to focus on this particular fixation. We're going to call it the AO joint from now on, just because it's a lot easier than saying atlanto-occipital joint for the entire presentation. So the skull or the head, it sits right on the superior articular facet via the occipital condyles. Brian, would you be able to show that on where those condyles are on the skull in the image on the right? You can see those blue images there that's on that skull. So then those particular articular areas are going to then fit right into the articular areas of the atlas. And you can see there in the callouts there where it says superior articular surface of the lateral mass. So it's really quite interesting that the head sits basically balancing on this very, very small area on that atlas. So let's go to the next slide then. Now, this joint is a small range of motion that's going to be approximately 10 to 15 degrees of flexion and extension. So that's going to be the movement of basically nodding yes. So it's the very small movement of 10 to 15 degrees of flexion and extension of nodding yes, which is a difference between full cervical flexion and full cervical extension. It's just that small little movement of nodding yes. Now, some researchers are going to agree that there's also a little bit of movement in lateral flexion or a lateral tilt of the occiput on the atlas. And we're going to discuss that a little bit there too when we get into the assessment. Now, the suboccipital muscles that are located deep to gallbladder 20, and also the semispinalis capitis muscle, especially these superior fibers, they're going to be primarily responsible for this action. So those are going to be two muscles that we're going to be definitely treating and linking that with their sinew channels. Let's go to the next slide. I want to discuss a little bit about how the angle of pull here. So on the left, you see an image of the 4 suboccipital muscles that surround gallbladder 20. So you can see the angle or the line of pull of these suboccipital muscles. They're going to go ahead and just tilt the cap or tilt the occiput into extension. Now on the right, you can see those upper fibers of the semispinalis capitis. Those will also be tilting the cap or the occiput into extension. So let's go through that language again. You've got cervical extension, but then with that small little movement in the AO joint, it is capital extension or a little bit of a tilt. If you take your fingers and put them right over gallbladder 20 on yourself, and once you're there, just look to the ceiling. You're going to have a small little movement of capital extension. So what you're feeling then is these upper fibers starting to contract and holding that area in place. So therefore, if you have a posture, let's go to the next slide there, Brian, if we could. If you have a posture where the person's going to be stuck in capital extension, for example, this image on the far right, the upper right, where the head is basically stuck in the end range of yes or capital extension. Many of our patients who have cervicogenic headaches or clouded thinking, low back pain, neck pain, have this particular posture, which you see on the upper right. That head is stuck in capital extension. So therefore, the AO joint is locked. And then the soft tissue around that AO joint actually starts to become adhered and locking that position. Now, you also have people that we have the end range of yes. So you can see on the lower right, that person is going to be more into a flexion of that capital. Now, that can also be a fixation of the AO joint and also have muscle and soft tissue balances as well. All right, so let's talk about those soft tissue balances because we're going to be looking at that for treating with acupuncture. Now, with all vertebral fixations, including the fixation of this AO joint, it's going to have the myofascial imbalances between left and right sides. Now, this is especially apparent with the suboccipital and the semispinalis capitis muscles. Now, often there's going to be a lock short muscles, which we can be able to label and treat as an excess on one side of the joint, which is really holding and locking that joint. And then on the opposite side, there'll be locked long muscles, which we can categorize as deficient, and they're inhibited, they're weakened, which is going to predicate needle technique that we're going to be talking about here in just a little bit. And that'll be on the opposite side of the joint. Now, this image on the right, this is going to be of the thoracic spine. So you can see there's going to be locked short excess on one side and lengthened and deficient on the other. For this particular conversation, we're going to be looking at the upper fibers of the semispinalis capitis and also the suboccipital muscles that we can treat with UB10 and also specific needle technique for gallbladder 20. One side will be excess and the other side will be deficient. And this is something that you can often feel just with palpation. And we've got a video of this we can be able to show you here in just a little bit. So not only these local needles that we're going to be using, the extraordinary vessels of small intestine 3 and UB62 work exceptionally well to be able to help with releasing that occiput and atlas fixation as well. There's going to be other muscles that we want to look at and associated channels that we want to look at that could be actually fixating the AO joint. And I think we can hand it right over to Brian so you can get into that. Brian, are you ready?
Mm-hmm.
Are you set?
Oh, okay. So I don't know, Matt, did you mention the inclusion of SI3UB62?
Yep, at the very end, the extraordinary vessels,
Okay.
the Duma, Yang Chow. Yep.
So we'll come back to that in a second. So looking at the primary channels associated with it, we have really a combination between the urinary bladder and the small intestine channels, sinew channels. We'll go with the sinew channels. So just to get a quick overview, we're not going to go through the whole channel for this lecture, but I have it listed here. In terms of the myofascial structures that are part of the UB Sinew channel, it's primarily what you'd expect, kind of running up the posterior part of the body following the urinary bladder channel. But let's take note of these little branches that sometimes we forget about if we don't look at the Sinew channels that branch from the primary channel going up and down the back, and then wrap around the front, and then wrap up to the shoulder. So we'll look at this anatomy in a second, but we can just briefly see this latissimus dorsi wrapping around to the pecs, and then linking. For this lecture, what's really important is the sternocleidomastoid. And then we have another branch that comes off of this region also and links with the upper trapezius. So that's one thing. And then the last thing to look at is this binding region that we've already discussed at this suboccipital region. So let's start with the suboccipitals. Matt's already talked about them. This image is nice because we have a slightly different angle, and we can get an appreciation not only for the rectus, capitis posterior, major, and minor, and the angle they take, but how sharp of an angle that we kind of miss out on when we look at those images that are going straight from the back. We kind of lose track of how much sort of an angle these oblique capitis muscles have. So that's kind of nice to see from a slightly different angle. But collectively, these are going to have a really big influence over the balance of the suboccipital joint. And seeing the angle these muscles take, you can see how imbalances between one side and the next might not just have that extension aspect that Matt's talking about, but also that ability to sort of have the head not sit on quite straight. So really, really key muscles, the suboccipitals for the balance of this atlanto-occipital joint, but also really the balance of the whole urinary bladder sinew channel and the tone of that whole urinary bladder sinew channel. Included also would be the cervical extensors like semispinalis capitis. But then if we go to the branches that were discussed off the urinary bladder channel, we have the lats into the pecs, and then creating a myofascial plane with the sternocleidomastoid. Sternocleidomastoid is an interesting muscle. It's part of multiple sinew channels, definitely part of the stomach sinew channel, but it has this linkage with the urinary bladder channel. And I'll give you one indication where you might have kind of seen something related to this is when you've learned about points and learned about urinary bladder 60, that is a common point for headaches. But the description, if you go back and just read the commentary, say in Deadman, the description of that often talks about yang rising, excess yang rising up the urinary bladder channel. And the way I kind of interpret that is that tension that rises up the back when people have a lot of, say, liver qi stagnation, a lot of rising liver yang rising, but it often rises up that urinary bladder channel and everything tenses up, SCM, upper traps, the cervical muscles, the back muscles. It's kind of that raising of the shoulders that happens and that scrunching of the neck that happens. So it's a very typical stress response, and these muscles are very involved with that. But they're also, because of their mechanical attachments at the mastoid process for the SCM, and then the upper traps going all the way up to the EOP, they can also contribute to that capital extension and that discrepancy from left to right. So they're accessory muscles. They're muscles we can also consider as part of a treatment when we're working with fixations at this region and things that are associated with that, like cervicogenic headaches. Okay, quickly going through the small intestine sinew channel. We have multiple structures. We're not going to get into them all today, but levator scapula is a big one, and that binding region that happens at the upper cervical region. Let's look at an anatomy image of that. Levator scapula actually attaches to C1 through C4 transverse processes, so it has an influence on much of that upper cervical spine, but especially that C1 transverse process, and it can be a big contributor to that tilting of the head from side to side. So a discrepancy in terms of how that's going to balance not just the position from capital extension, but that maybe shortening and raising of the shoulder on one side and that discrepancy from side to side. So levator scapula is another one that can be a player in this and can be an accessory muscle. Treating the suboccipitals is important. We're going to be looking at a technique at gallbladder 20 and semispinalis capitis at UB10, but don't forget about levator scapula. It's a good one to consider in this whole list. So collectively, these two channels are going to meet and kind of have a binding region at that upper cervical spine, uh, atlanto-occipital joint region, the suboccipital region, and collectively are going to be a part of that whole balance of the AO joint. So here's a nice image showing that upper fibers of the levator scapula meeting at the transverse process and then communicating mechanical information with the oblique capitis superior and inferior muscles, which are two of the muscles of the suboccipital triangle, two of the suboccipital muscles. So they can really work together in terms of balancing, but also become dysfunctional together. All right. So kind of ready to look at some images. Go ahead, Matt.
Yeah, Brian, so let's get into these and talk about these. I think this is a nice segue into that discussion of the upper trapezius and the levator scapula as well. So the image on the left, you can see that she's got a bit of a lateral tilt of her head onto the AO joint. You can see how that left ear is slightly lower than the right ear. And this is something also that you see with patients. Let's say, for example, that you're sitting on a stool and the patient's sitting on the table right in front of you. Have you ever noticed that it looks like their head's just not quite on straight? So their head's just slightly tilted. This is something like you would see on the left. And I'll guarantee you 99 out of 100, if you go back and you palpate the gallbladder 20 and the bladder 10 region, one side will feel very excess and the other side will feel very deficient. And something that we're going to discuss here next is that that person will also have bilateral psoas weakness. So we'll talk about that here on the next slide. But for right now, that image on the left, you can see that they've got a little bit of that lateral tilt. Same thing with the image on the right. This gentleman, you can see his tilt on the right. So the levator scapula is going to be in a locked short position on that right-hand side. And he most likely has an Occiput-C1 fixation as well. So these people could have cervicogenic headaches or any of those aforementioned signs and symptoms that we had. Brian, do you want to talk about the capital extension there on the remaining two images?
Yeah, I would agree that the big structures to consider on these ones that Matt talked about would be the suboccipital muscles. Are so influential on the tone, but it seems to me, without having any other information on these patients, what they're coming in with, etc., it seems to me like levator scapula would be indicated for those. Whereas these pictures on the right, I might change my tune if I saw them from the back, but at least from the view from the side and this excessive capital extension, the suboccipitals are going to be involved with that. But I would also be looking at the SCM for both of these patients, and it's going to be the case that one side's going to be shorter, and that's going to contribute to that tilting of the head not being quite on straight. So it would be an accessory muscle to consider along with the suboccipitals and semispinalis capitis, especially if they're coming in with headaches, and it seemed like the SCM was a component of that headache, maybe referring into the frontal region or deep into the occiput. SCM would likely be involved with that. Maybe even upper traps. All upper traps are kind of in a position where they're pulled forward. So we'll be including in this discussion, after looking at some local needle technique, we'll be including a myofascial technique that you can refer back to those two right images when we're talking about that myofascial technique, and that would be the type of patient that the technique we're going to show would really shine.
Yeah, that's a good point. I would suspect the image on the far left, that her left upper fibers of the SCM would also be really quite locked short. Same with the gentleman on the right. I would think that his SCM on the right would be. Yeah, that's great. Holding this fixation in place. Now, you guys, we are zeroing in on the AO joint. For those people that might be looking at the posture on the left images there, yeah, of course, the elevated ilium and the side bends of the spine and such, all of that would have to be addressed, right? Which we do in the different modules in the SMAC program. But for right now, we're just kind of zeroing in on this AO joint and how important it is to observe and treat it for different types of signs and symptoms and pain patterns. All right, so the next slide is an assessment from applied kinesiology. So this is George Goodhart's work, but I'm not exactly sure if it came from him or maybe John Fee in Touch for Health. I'm not exactly sure which one. But yet with an occiput atlas fixation at the AO joint, it will create bilateral psoas weakness. So therefore, if somebody has this muscle that's inhibited, and therefore they're going out and doing um, extracurricular activity, hiking, doing something above and beyond, you could see how that muscle would be struggling and eventually could actually strain. So when somebody has a hip flexor strain, it's affecting that psoas, it's always a good idea to go up and look at the AO joint. Now, since the psoas is not going to be stabilizing that lumbar spine as well, being inhibited from a fixation at that AO joint, it can also create low back pain. So this is a really great assessment looking at the psoas. And then once you correct the AO joint with acupuncture, and also we're going to be showing you a little bit of a manual technique that you can use, and also a myofascial release technique on the upper trapezius that's affected as well. You would then go back and check the psoas for strength. And if it is not bilateral psoas weakness anymore, so then therefore you've done your job. With some patients, it might be then unilateral weakness, meaning it's just one psoas that's weak. That means that the AO joint is still corrected. Remember, with a fixation, it's bilateral weakness. If bilateral weakness turns into unilateral weakness, it then becomes more of a segmental problem or just a localized problem, which we could go ahead and treat the Wato Jajis of the T12 down to about L3, as well as GB27 on that particular side in order to be able to turn that psoas right back on. Cool. All right. So what do we got next here, Brian?
I will say one quick thing about that. It seems odd, right? The psoas and the Occiput-C1, there's not a direct innervation. It's not like the psoas is getting its innervation from C1. But if you wanted to just look up something called the oculopelvic reflex, it talks about the relationship between the eyes, which have a strong relationship with the suboccipital muscles in terms of turning the head following eye movement, and the pelvic position and really the lower spine position. So it's probably a reflex component that's communicating between eye movement and stabilization of the spine. And maybe that gets turned off when there's an Occiput-C1 fixation. Just theory, but it's really more a clinical observation than it is a direct anatomy thing. But that's what I think it kind of works according to those principles.
Well, that's something that you teach and demonstrate in the Sinew channel class. And it's really quite
Mm-hmm.
interesting to feel the psoas fire when the eyes go left or right with that. So that relationship,
Yeah.
thanks for bringing that up, Brian. That's a
What,
good
what
callback.
Matt's
Good.
referring to is like if you're somebody seated and you press into the abdomen and can touch the psoas, you often feel it firing slightly when people look up to the corner, which will the suboccipitals will start to fire, and you can feel that tone change. Like I can have my eyes closed and be like, okay, you moved. Sometimes you don't feel it, and maybe those people you don't feel it as well, or you only feel it on one side. Sometimes it's quite prominent, sometimes not so prominent. Maybe the people it's not really prominent on are the ones with the Occiput-C1 fixation, but you can definitely feel the psoas communicating with that small little eye movement that's happening and the small head movement that occurs from that.
Mhm.
All right,
Cool.
so next slide. There we go.
All right. So when you're feeling the gallbladder 20 suboccipital region and bladder 10 left versus right, when somebody does have an AO fixation, one side definitely feels more pliable, more deficient. The other side is harder tissue. It's more dense tissue. It's usually a bit more painful to palpation. So with the excess side, what you could do is to go ahead and palpate gallbladder 20, but in three different directions. So from gallbladder 20, if you angle it toward the contralateral gallbladder 1, you're going to be affecting the rectus capitis posterior, minor, and major. If you take your finger from gallbladder 20 and you angle it toward the ipsilateral gallbladder 1, it's going to be affecting the oblique capitis superior. And then from gallbladder 20, if you angle toward REN 24, you're putting pressure into the oblique capitis inferior. So whichever one is actually the most tender or may even creates a headache is the angle that you want to actually needle from gallbladder 20. Now, if you needle 1 to 1.15 inches in any of these directions, that's going to be totally safe. It is safe to be able to do that. The only one that you want to make sure that you're definitely needling toward the ipsilateral gallbladder 1 from gallbladder 20 to affect the oblique capitis superior is 1 inch to 1 to 1.5 inches. That's not an inch and a half. It's 1 to 1.5, so just over an inch. Needling that direction will be very safe. If you do go toward maybe the ear, maybe you're going too fast, you're going to be very close to the vertebral artery in its unprotected region. So we want to make sure that we're not angling toward GB27, GB12, or also the ear in that particular case. And then bladder 10, if we can go to the next slide there, which I think it just continues to discuss. Let's go to the next slide, Brian.
Yep. Yeah, I tried to. Maybe it's try it again. Ah,
Is it,
sorry.
is it stuck?
Okay. Nope. There we go.
All right, so there we go. So then bladder 10 is going to be the key point for the semispinalis capitis. Now, as we know, the way that we were taught is bladder 10 is going to be level with due 15, and gallbladder 20 is level with due 16. For the last, this particular image is from the Motor Point Index that was published in 2000, the year 2000, I believe, was published. And so the information has changed. We have found the actual motor entry point for the semispinalis capitis, the upper fibers at least, to be level with due 16. So that means that we're putting bladder 10 level with gallbladder 20. And frankly, from my own clinical experience, I think Brian can agree with this as well, is that treating the upper or the modified bladder 10 level with due 16 and also level with gallbladder 20, you get a lot more chi sensation than you do when it's level with due 15. But don't believe me, try that yourself, you guys. Make sure that you're needling one soon perpendicular to the table or to the floor, going in level with gallbladder 20 and due 16 compared to level with due 15. I think you'll find you'll get a lot more chi sensation at that particular point. So the next slide is actually showing another view. Semispinalis capitis, you can see how it's just between gallbladder 20. We've modified this and we're putting it level with gallbladder 20, everybody. Yeah, you get a lot more chi that way. All right, so the video you're about to see is going to be needling bladder 10, 1 inch perpendicular to the floor. On one side will be the excess side, and then on the other side will end up being gallbladder 20. So it's not necessarily going into the 3 different directions. We're just needling gallbladder 20 on this particular side, which you can do. But a good idea on the excess side is to palpate those 3 directions, affect that suboccipital triangle. I think you'll get better success rate for releasing the AO joint. This particular video, the audio didn't turn out very well, so I'm going to go ahead and narrate this as it goes. So Brian, whenever you're ready, I'm ready. All right, so we're going to be looking at, there's due 16 right there. This is going to be for your AO joint fixation, due 16. Right, so I'm going to go ahead and palpate on the right-hand side, and that feels really quite dense there at bladder 10, which we know is going to be about 1.3 soon lateral. That's going to be the upper trapezius that I'm working my finger through to get to the deeper layer, which would be the semispinalis capitis. Moving lateral, going into gallbladder 20 and feeling the density of gallbladder 20. Now going over to the left-hand side, bladder 10, more pliable, softer tissue, easier to get in. Gallbladder 20, more pliable, soft tissue. So it'll be excess on the right, perpendicular to the table of the floor, going in at bladder 10, 1 inch. You could even go in 1.25 inches here. I do recommend a deeper needle technique at this particular point to get into that semispinalis capitis. Then a gallbladder 20 on the right. We're going to needle just toward the tip of the nose in this case at gallbladder 20, but this would be the area that we could go ahead and palpate the 3 different directions for the suboccipital triangle. In this particular video, we didn't. Now on the left-hand side, we want to reinforce this. So this is going to be a shallow needle technique. Going right into that upper trapezius, going in just about 1/4 of an inch, no more than 1/2 an inch in that area, a very light chi sensation compared to the opposite side. And then a gallbladder 20, the same thing, going toward the tip of the nose. Very, very light needle sensation here, more of a reinforcing needle technique. From clinical experience, going in and really wailing on these areas or getting a lot of chi on areas that are deficient will actually make the person a little bit worse. So deeper on the right-hand side, more of a reducing needle technique, more superficial on the left-hand side, more of a reinforcing needle technique.
This
Okay.
video is on our YouTube channel, by the way. I know sometimes streaming it can get a little choppy, but if you wanted to go back and look at it again, it's on our channel, Sports Medicine Acupuncture.
All right, this is a really great muscle energy technique for the suboccipital triangle muscles. I believe it was developed from Philip Greenman in the 1940s. He's a very famous osteopath that has quite a few different books out. It's a great technique to be able to use right after the needling and after the myofascial work as well. You can even use this type of myofascial technique when there isn't an AO fixation. It just helps to really relax the patient quite a bit. So this is a step-by-step. You can see there's these different slides that will be in your notes here or in this recording here that you guys can be able to check out. It's basically gently pulling the person's head into traction, and they're going to look back at you to help to stimulate those suboccipital muscles. And then once they relax, you're then going to go ahead and just elongate the head and traction a little bit further. So it is a muscle energy technique where they contract against you. You prevent any kind of movement for about the count of 6. They relax, and then you pull the head just a little bit farther. So you're helping to realign the occiput onto the atlas. Again, it's a fantastic mobilization technique.
Here's the other rest of the instructions. So like Matt said, if you go back and access this recording, you'll have those.
We also have this, I believe, in module, is it module 1 Sinew channel class, or is that would be going to be module 4? It might be module 4 Sinew channel class that we actually have this video as
well. Oh yeah, on Net of Knowledge, yeah, that's correct. It's module 4.
Yeah.
All right, so one more technique, and this one will highlight that branch of the urinary bladder sinew channel that's connecting with the upper traps and the SCM. In many ways, it's working with the fascia of that surrounds both the upper traps and the SCM, which are embryologically one muscle that splits. So they really have the same fascial compartment, same fascial bag, and this is just taking the fascia and bringing it back. So this video has a lot of different steps. We're going to not watch the whole thing. We're going to watch just a portion of it that's relevant to this discussion. So I'm going to kind of go a little ways into the video. Let's see. Nope. Might not be able to. Yeah, there we go. Okay. And same thing, I'm going to be narrating this just for sound aspects. So we're going to use a loose fist, and that loose fist is going to place right on the upper trapezius, kind of on that border of the upper trapezius. So we want to not put a lot of pressure so much. It's just enough to get a hook into the tissue, and then we're going to bring the tissue down towards the table, back really, bring the tissue back while the patient rotates their head to the opposite side. It's kind of like when I learned this technique, I think we used the description of a velvet glove, which kind of is a nice way to think about it. You want a soft pressure. Doesn't mean it's not deep, it's just not pushing into the tissue deep. The next step, we can follow up that same fascial compartment up through the SCM. What I'm highlighting is I don't want to go in front of the SCM with my fist. I want to be on the SCM. I don't want to go in front of that border. Same thing, I put in just enough pressure to get a hold of the fascia. If patients are hyperextended like that, I want to use that pull down towards the table to help straighten and elongate the back of the neck. I might even have them bring the chin in a little bit, and then they rotate while I'm bringing that whole fascial layer back to the almost to the spinous processes, as far back as I can reach it, while they're rotating. So it's not a lot of pressure into the neck. It's more about hooking that superficial layer of the cervical fascia and bringing it backwards. And then I can have them do it again with another pass. What I'm showing there is when they turn, I want them to rotate on an axis and not bend the head to the side. It's almost like they have an axis or a pole going through the spine that stays straight. So it's just they should almost feel their hair scraping along the table as they do it. And I'm bringing that whole superficial cervical fascia back. So it's a nice technique to help decompress the back of the neck and elongate that fascia that's associated with many things, but the Occiput-C1 area for this lecture.
That's great. So, Brian, we've got the proverbial hook coming to pull us off the stage right now. So
Yeah,
let's get through this within the next 30 seconds or so. So,
yeah,
you
for
guys
sure.
have the new and approved sports medicine acupuncture certification program starting in San Diego here in July. There is the QR code. We're happy to answer any questions that you guys may have. And then also in March, end of March of next year, we have a Psoas event, the Pacific Sports and Orthopedic or Acupuncture Symposium. That is the acronym Psoas. And this is going to be based on myofascial pain. We've got incredible speakers that are coming, including Dr. Antonio Stecco, Dr. Rebecca Pratt, Ira Nielsen, Brian Lau. I will be there. Dan Bensky. We've got a great list of people that are coming to present. There's the QR code for that. We've got a lot of online recordings as well that we can be able to further your continuing education. And that's going to be through LASA OMS here in the United States, Eastern Currents in Canada, and there is also distributors international for that. You can also follow us. We've got YouTube and Facebook and Instagram. And Brian, you want to give a shout out for your movement therapy?
I've been putting together a lot of description of movement associated with the channel sinews. So it's a lot of body weight calisthenics, some qigong, tai chi, various things. But it's not about what the exercises are. It's really looking at it more from a channel perspective, how you train those channels, wake up those channels, and incorporate like really efficient movement with those channels, and then you can start strengthening those channels. So Jingjin, channel sinews, movement training, QR code, or you can just do a search for Jingjin movement training. All the other stuff we mentioned is sports medicine acupuncture. If you go on YouTube and you don't have the code with you, just do a search for sports medicine acupuncture for any of those. All right, I
Fantastic.
believe that it.
That's it. Yep. Hopefully this was useful for you. There was some pearls for you guys to be able to grab and help out some patients, because that really is the bottom line. We want to be able to help other people. If you have any questions whatsoever, please reach out to us. We're happy to be able to answer those questions. Next week, Cho Lin Moy, who's going to be coming. I was really happy to be able to hear that she's actually going to be presenting. Cho is a fantastic speaker and an incredible practitioner. She's one of Kiku Matsumoto's top students. She took the sports medicine acupuncture certification program twice, and she's blending the two things together, and she's just a ball to listen to. She is just a walking dictionary. Amazing. Cho Lin Moy for next week. Thank you very much, everybody. Thank you so much for the American
Thank
Acupuncture
you.
Council for having us. Brian, it's always great to hang out with you, buddy. And we'll see you again soon.
Yep. Bye bye.